Here is an example of a lipoma, but fatty lobules on real-time scanning can interlace and interbraid, and they don't have abrupt interfaces with the surrounding tissue, and that's how you can tell they're fatty lobules. So I can't overemphasize the importance of real-time scanning with breast ultrasound. Looking at static images are really just not enough. You really need to go in there sometimes. Now, in most of the world, breast ultrasound is done real-time, but in our center, we actually have a breast sonographer who does our breast ultrasound, and she'll show us pictures, and she'll say this is a mass or this is a cyst, or she'll tell us what she thinks, and most of the time what she thinks is right, but sometimes you have to go in and scan for yourself, because what may look like a mass on a static image ends up not being a mass when you scan it in the two planes, radial and anti-radial, or sagittal and transverse. Here's an example of the thickened skin, greater than 2 millimeters thick. Here's a male breast, and this is the ultrasound picture of what gynecomastia, or the development of male breast tissue, will look like. Just normal ducts as they radiate from the nipple area. Here are some other ducts. Now, with really high resolution equipment, we can actually see inside of the ducts. Here's a little bit of fluid within the lining of these ducts. We can actually see this bright white line, which is the lining of the duct. It almost looks now like we're looking at, an endometrial lining. Of course, you don't see this all the time, but sometimes you can, and this is just a picture of a perfectly normal duct. And here's fluid in a duct. That's normal to see sometimes with ductal ectasia, but what you're looking for when you see particularly prominent ducts are masses or filling defects or areas that look like nodules within the duct wall. And here's a rib, which you can see when you're scanning all the way through the full thickness. Lymph nodes are interesting, and they occur throughout the breasts, and we see them really commonly as normal structures when we're doing routine breast scanning. On a mammogram, this is the typical characteristic appearance of a lymph node with its fatty hilum. On the ultrasound, the fatty hilum is bright because in comparison with the cortex around it, it has more brightness, and the fatty hilum is bright on an ultrasound in a lymph node. Here's an abnormal lymph node. Abnormal because it doesn't have a nice centered fatty hilum. Rather, the fatty hilum is displaced over to the side. The lymph node looks a little bit more hypoechoic than it should. It hasn't lost its nice ovoid shape yet. Really markedly abnormal lymph nodes will turn round and large. We don't usually use size as a criteria for calling a lymph node abnormal, because normal lymph nodes can be quite huge, actually. We use more the shape of a lymph node and whether or not it has a fatty hilum and what that fatty hilum looks like. Here's a good lymph node and a bad lymph node. Here's the appearance of the good lymph node with the echogenic fatty hilum. Here's the bad lymph node, which actually looks like a suspicious mass, but upon biopsy this showed to be a lymphoma with kind of a disrupted fatty hilum and abnormal shape. So for evaluation of masses, size, shape, margins, internal echotexture, and acoustic properties, and how this mass appears against its surrounding parenchyma are all things that you look at to try to determine whether a mass has benign characteristics or suspicious or malignant characteristics. And to do that, we want to adjust our focal zone, putting the focal zone right at the region of the mass. You want your gain to be appropriately set. And appropriately set is, since we're judging masses in comparison with the surrounding fatty tissue, you want your fatty tissue to be just right. And what's just right? Well, I wish we had a number or something definite to say. Other than that, the fatty tissue should be kind of a charcoal gray color, or what my coworker likes to call it, a flannel gray. I like that flannel gray, because that's what it should look like. It shouldn't be black. It shouldn't be overly bright. It should be a dark gray so that you can judge everything against that. Your time gain compensation curve should be adjusted appropriately so that the fat looks that charcoal or flannel gray, and that your depth is appropriately visioned, and that if you have a mass in the very near field, you can use a gel pad for that. Gel pad can still show things that are very, very close to the skin. Most modern equipment, focal zones will cover that area, but if you feel like your focal zone isn't really getting to the area that you're seeing, if it's that superficial, use a gel pad, which will bring your focal zone into the zone of the mass. Other things such as compressing the mass to see if it's compressible, elastography, fremitus, position change to see if the mass changes position. All these things can also be used, but more often it's just your basic things that you use with other forms of ultrasound, making sure your focal zone is right, making sure your gain settings are right, and making sure your depth covers the area that you need to see. We add Doppler when we want to find out whether a mass has blood flow or not. Other add-ons to ultrasound equipment have proven to be helpful, such as spatial compound imaging, harmonic imaging, extended field, and 3D. Doppler we use mainly to confirm whether a mass is solid versus cystic. In other words, if you throw the Doppler on and you see internal blood flow, you know it's not a cyst. Lymph nodes, you can sometimes see that nice characteristic fatty hilum, which will show you that this is a lymph node and not another type of mass. We use Doppler for pre-biopsy to make sure we're not headed into some particularly vascular area. If you have a choice, you'd rather not do that. And vessel characterization is always being studied to tell whether or not once you see that blood flow and once you get that waveform, whether or not we can tell something about that waveform, which will help us decide whether this is a waveform associated with benign vessels versus tumoral vessels. So here's an example of blood flow within a mass that Doppler ultrasound has shown us. Here's a good example of something that some of us may call a cyst with debris in it. This almost looks like a level of some sort, except the level's not exactly going the right way. This patient is supine, so if this was a fluid debris level, we should see something like that. So it's kind of off to the side, but still this could just be some concreted debris within a cyst. But then when we put the Doppler on, we can see that there's blood flow within this area, arterial blood flow. So that certainly wasn't debris. That's actually a solid component of this now suspicious-looking cystic mass. Here's an implant, and here's two masses outside of the edge of this implant, and we may think that this looked like silicone, because silicone outside of an implant can look exactly like this. But when we put the color Doppler on, silicone extravasation should not have blood flow in it. These were actually masses outside of the implant and not silicone. And again, as I said, here's some kind of large, dense lymph nodes. Again, we don't necessarily use size, but sometimes density on a mammogram, and it shows this characteristic hilar flow, Doppler does, of this lymph node. Compound imaging is a technique that is particularly good for showing us margins, which are, of course, one of the things we look at very carefully with masses. Here's a scan done without compound imaging and one done with. Now, it still is not popping out at us, but here I would say I have trouble seeing almost anything. But here I can see that here's a mass that has spiculation and made better with the advantage of compound imaging. What compound imaging does, it steers the transducer array to allow for multiple scanning angles rather than straight down into the breast, and it results in a reduction of speckle, clutter, and artifacts, and improves detail of mass margins and calcification. One little problem is that features of posterior enhancement, which we rely upon a little bit, are less apparent. So here's an example of one of those screening MRIs which show an abnormal enhancing mass, which on traditional conventional ultrasound we really didn't see. We put the compound imaging on and the mass becomes more apparent, and in fact we see some speculation associated, and we're able to now measure it and biopsy it using the ultrasound. Here's one of the disadvantages of compound imaging. Here's conventional imaging where you see this mass, although, you know, as I said earlier, this actually isn't what I'm going to call a cyst because it doesn't have totally smooth margins, but it does have enhanced through transmission. In compound imaging, the enhanced through transmission, the clear band of it that you see here, is made a little less apparent. So if you do have compound imaging on your ultrasound machines, you're going to want to use it for marginal analysis, but then kind of take it off and use conventional ultrasound to show whether or not there is enhancement. Harmonic imaging is another type of imaging that we use for many parts of the body. that has to do with transmitting at one frequency and receiving back to the ultrasound transducer at multiple of that frequency. And it produces images that have reduced artifact and reduced reverberation, and great to clean up cysts. We use it a lot in the body for liver and kidneys, and we can also use it in the breast to make cysts. I'm sorry if this image is a little dark, but actually if you had questions that there were internal echoes, as long as your background fat is that charcoal or flannel gray, and you put on the harmonic imaging, you can kind of make those artifactual echoes go away. So the point of harmonics is to make artifactual echoes go away. Now, of course, you can make echoes go away by inappropriate gain settings, turning the gain down, such, but as long as your gain settings are appropriate from the start, that's when you add the harmonics. 3D improves the visualization of mass margins and improves needle localization. We don't use 3D on any kind of routine basis, but I suppose that it can be helpful because we do ultrasound follow-up when patients are on neoadjuvant chemotherapy and they're shrinking the tumor before they actually do the biopsy or take it out. And estimation of tumor volume is obviously better when you see a mass in 3D. We think we do an okay job with that in 2D, but obviously 3D is better. Panoramic imaging is good for locating multiple masses and correlating those multiple masses with the mammogram because it looks a little bit more like the mammogram. Here's an extended field view of the entire breast. This is the old-fashioned water bath whole breast ultrasound, which really looks more like a mammogram because it maintains the shape. This was done and isn't done anymore except for sometimes research purposes, but where the breast was actually patient prone and the breast was kind of down in a water bath. But we may see a little bit of a comeback with this as we kind of look more into panoramic imaging. So that's the end of the presentation. I hope to have provided you with an overview of the many useful ways that we use breast ultrasound and to refer you to published manuals which can then take you a step further into distinguishing benign from malignant masses, but most important is your technique, is your patient positioning, your labeling of the ultrasound images, and your correct usage of this wonderful technology that we have, breast ultrasound. Thank you.